So when we're discussing pandemics more than anything else, or any transmissible disease, the idea here is that, again, they become more effective when they have a lower serial interval. So remember, lower serial interval means that there's a shorter distance of time between the onset of the first set of symptoms or signs and the next one. So shorter here, the situation that you're seeing on the left-hand side of these slides, means a shorter period of time. So a lower SI, a lower serial interval, means 3 days as opposed to 7 days. That's the example that we were working with earlier. So ideally, the logic would be is that if we want to control some sort of type of disease spread, we would like to increase the serial interval. We would like to make the SI larger, as well as lowering the R naught. The idea here is not necessarily to truly kind of eradicate the disease, but that's the aim. Increase the SI, lower the R naught. That's what we want to work with, at least right now. So the example that we were trying to give you earlier is more behind application. And before we kind of focus on the pathophysiology of the disease and everything else, let's kind of give you this idea of how we can control any type of epidemic or even pandemic, right? So remember, think about the formula and the factors that affect it. And so the formula, remember that R naught specifically depends on that effective contact. Meaning, how many people does that person that is infected literally come into contact and those people get infected. So technically, a smaller EC or effective contact means a smaller R naught. Now for this serial interval, remember that that factor can be changed because it's based on time. So a longer period of time means a longer SI as well. So here are the basics that we want to work with that, right? Is that even though we're not really considering it at the moment, but the idea would be that we would like to eradicate the disease, meaning that we want to have an R naught of 0, so a no value to our R naught. However, to be able to accomplish this, we kind of require this combination of two specific methods. And so here's what we have presented on this slide, right? The first method to truly kind of decrease the spread of any type of disease is obviously to stop its transmission, to block its transmission. Meaning that if there are any sick patients, for example, we would like to call these cases, obviously, since we've confirmed that they have been infected, and we would like to isolate them. So any patient that has been confirmed, meaning a case, in this case, has to be isolated. That's one idea. You're preventing the transmission of a person that has already been infected and preventing them from infecting others. So isolation is part of this process, right? Now, more than anything else, also, one of the most effective methods to prevent transmission behind this particular pathogen is to use PPE, right? This means the use of our personal protective equipment, especially for our healthcare providers, and this idea of your masks, your gloves, your coats, and everything else that also kind of reduces the ability for the agent to go from one person to another. And so this is, again, I reemphasize the same thing you've been hearing for the last several months, is this idea of even masks make a difference here, and a significant one overall. But isolation is primarily the main one. Now, since we want to stop the transmission, that's one level, but we can also prevent further transmission later on. And so we'll discuss this as we go into the immunology portion. But vaccination happens to play the larger role. So depending on how good the vaccine is, mind you, so certain vaccinations are more effective than others, right? But the idea, they have the potential to fully stop transmission, okay? And so again, we will deal with this once we get into the immunology lecture. But if you cannot vaccinate, or if we don't have a vaccine available, then the most common way to prevent transmission is by reducing crowds. The idea would be to reduce the effective contact. And so what you've already learned for, again, the last few months is this idea of what you've heard as this concept of social distancing, right? This idea that we want to reduce the amount of contacts that everybody has to prevent that transmission. You've probably also heard of this as that term that we mentioned before called flattening the curve. This idea that the amount of cases that appear on any given time point will be lowered, or flattening a curve, if you will, simply because of the fact that less people are coming into contact with others. Right? Now, mind you, again, prevention is not a cure, it's just a deterrent, right? Meaning that all we're doing is literally delaying it. So this may not sound as great of saying, well, why are we preventing the inevitable? So I want to explain why this is also an important concept. Just because we're slowing it down doesn't make it bad. So yes, effectively, we would like to stop its transmission, but if we can't stop it, or at least we haven't figured out a way to stop it, we would like to at least slow it down. And we'll show you how valuable this concept of slowing it down really is. So let's show you here a hypothetical scenario, right? So let's kind of show you why these first set of slides that we've shown you are kind of really important from a practical standpoint. So as you've been hearing, the CFRs and the R0s that you've been hearing around, but let's kind of give you this idea of a very, very basic set of math, right? So let's just say, let's pretend that the virus only usually hits one person in every 100. So basically 1%, if you want to do the calculation yourself, right? 1 in every 100 Americans are affected. Now, if, let's just say again, it's hypothetical. Let's just say that out of those 1%, okay, about 1% of them require critical care, meaning ICUs, okay? That means 1% of 1% equals 0.01%, okay? So that's pretty much 1 in 10,000. So in other words, we're declaring it as if 1 in 10,000 people requires hospitalization. That's, again, a hypothetical scenario. Now, currently, our population in the United States is about 330 million, a third of a billion, if you haven't done the math there too. And so if we do the 1% number, meaning that 1% of the 330 million gets affected, it's about 3.3 million people. Now, out of those 3.3 million people, if only 1% of those requires critical care, meaning hospitalization, that makes it about 33,000 people. Now, again, that may not seem a lot, but I want you to understand that in the United States, we have roughly around 6,200 hospitals, okay? And that's, again, roughly the estimated number between private and public hospitals. And that usually accounts for about 100,000 critical care beds. So that's what's available in our country currently, right? And so think about the disease. And if this disease is hospitalizing 33,000 people, we're literally taking up a third of the ICU beds. Now, that may not sound as a lot, but what about the other diseases? What about the rest? This is not the only one disease that is occurring. This is not the only big deal that is happening right now. Plenty of other diseases out there that also require ICU. And simply because this 1% of 1% are the people that require ICU, we've literally locked up a third of the available beds for our nation, right? So people kind of don't take this into account of going, well, it's only 1% or even 1% of 1%. Now, these numbers over here are entirely hypothetical. Now, based on what we've seen, this is a very conservative number. 1% of 1% is not very much, but even then, it's hitting 1/3 of the available beds out there for critical care. Now, what if I'm wrong with these numbers? What if instead it's 2% or even just 3%? 3 out of every 100 Americans gets affected. So if you start getting the bigger picture behind this, if 3 out of every 100 Americans get affected, at that point in time, we're going to take all 100,000 ICU beds. Done. We are saturated. And now people are going to start dying faster and more spread, clearly. So just the difference in 1% changes the dynamics of how our nation runs, or any nation altogether. So we only have, or we're lucky that we have 100,000 ICU beds available, and those are being taken up really fast. So one of the reasons of the previous slide that we're trying to explain earlier is this is why you want to consider that R naught. Even though it's a relatively inaccurate number to kind of post on media, we can reduce the R naught, hypothetically speaking, reduce that basic reproduction number as a way to, again, flatten that curve. Again, it's not a cure. It's what we're doing is slowing it down until later. And the idea, again, of slowing things down is that so we don't overwhelm our healthcare system. As I'm sure you've all seen over the news, we're running out of beds. We don't have enough healthcare providers out there. People, they are getting sick in and of themselves. So being able to access useful healthcare is becoming very limited. And again, that's if 1% of 1% is being affected and requires critical care. Okay, so this is a very dangerous scenario to be, especially when we don't have any immunity at all. We haven't developed any immunity, and since we don't have a vaccine, this is a very challenging situation. And so this is exactly what you probably heard, especially in the news or somebody trying to explain the disease, what happened with the Spanish flu. Okay, everybody kind of likes to throw that example of Philadelphia versus St. Louis, of this idea of one city acting first and this idea of flattening the curve. And I'm pretty sure you can find plenty of those videos online kind of explaining them. It's about slowing it down. People are going to get sick, but if we all get sick at the same time, we will overwhelm our healthcare system, and now people are going to start dying, and the spread of disease will occur much faster, right? So the idea here is if we can at least slow it down, meaning we can reduce our R naught, and we can increase the serial interval here, meaning extend the time that it takes for one person to get sick versus the other, at least we will have the hospital care available when needed. So again, it's all about not overwhelming the system, okay? Now, one of the key factors that it will help is vaccination. And this is where that R naught really comes into play. This is where that number is very, very useful. The idea here is that we can actually use a very simple formula called 1 minus 1 over R naught. That's taking that value and just kind of doing the inverted relationship to it. And we can actually estimate how many people need to be vaccinated to prevent the further spread. So what we're going to do next is a little bit of math, kind of going through that. So I'm going to go back to the cases we showed you previously, right? And so now I'm just going to give you the cases and the names of these diseases, right? Or at least diseases that mimic those states, right? So here what we have is we want to kind of keep things from spreading, right? That's the idea. So how are we going to do this? Let's look back at those hypotheticals from last time in terms of slightly different perspective, looking at the new cases. Now, when we look at, for example, MERS, which is scenario 1 that we have over there in the column, right? Let's just say that, for example, 100 people start being infected, and after one round of infection, if you will, one round of spread, those 100 people generate 40 new cases, okay? So that would mean that in the next generation of this 0.4 R naught that we're seeing over here, okay, what will happen is the 40 new cases, since they can only generate 40%, that means 16 new cases in the next generation. And then about 5 cases in the next generation, and about 2 in the next generation, and so on and so forth. And so what happens is, having an R naught of less than 0, so this is why we have this X less than 1 over here, right, becomes what we call a self-limiting disease, meaning that in and of itself, because you're not spreading it to more than the number of people that already have it, the actual disease will slowly kind of dissipate away. And so this is called a self-limiting scenario. Now, if we look at, for example, your classic seasonal flu, for example, that has an R naught of 1, okay, that means that for every one person that has it, the other 1% gets it. That means that if 100 people have it, 100 new people will get it. That means that the next round, another 100 will get it, and then the next round another 100, and so on and so forth. So this disease is considered stable. 100 people get it, 100 people get cured or recover, but another new 100 get it again, and so it never goes away. It's constantly being passed down. Now, what happens when your R0 factor is bigger than 1? So let's say, for example, something like Ebola, right? And so when the R0 is larger than 1, or X bigger than 1, in this case close to 2, that means that for every one person, almost 2 other people are getting infected, almost, right? And so that means this disease is considered to be propagating, meaning that more people keep on getting infected every round around, okay? And so at this point in time, if that continues, it will spread out and we won't be able to stop it. So this is where the situation gets dangerous. You see, for MERS, eventually it would go away. And even for the seasonal flu, it's kind of this stable or constant amount of people getting infected and other people disappearing. But in Ebola's case, this is wiping out every generation and then almost doubling each round around. So hence the R0 worth of 2, right? So we want to stop that spread. And now in the case of measles, in which you get this R0 of close to 15 or around 15, depending on which report you read, that's just taking over. And it's taking over really fast. So kind of keeping this pattern of numbers is a pretty kind of dangerous situation to be with. And if the current estimates, which again, we're hoping that they will change, the current estimates of COVID-19, in this case, or SARS-CoV-2, has an R0 roughly between 2 and 3, that means it's going to continue to spread and more cases are going to be about. It's going to be doubling to tripling every round around. So how do we stop this spread, right? Now, the reality is the first 2 scenarios that we're seeing here, the MERS and the seasonal flu, are not that much of concern. So I'm not trying to downplay, I'm just saying they're not as concerning as the other 2, okay? They're not really spreading enough to cause an epidemic. They're stable or self-limiting, meaning that eventually they can become under control, right? So remember that an epidemic, by definition, means a number above the usual. And so something that is self-limiting goes away. Something that has this stability of 1, okay, so an R0 of 1, is what we call endemic. That's what's always occurring. It's only when the rate goes above what is normal, so above the 1, that becomes the epidemic. So Ebola, in this case, and possibly things like measles and other examples that reach that state, right, are the danger. This is where the epidemic or possibly even pandemic can occur. So what do we want? How do we stop scenarios 3 and 4? Well, to limit scenarios 3 and 4 is actually kind of quite simple. What we want to do is change that R0 of 1.8 or 15 back to 1. So we want an R0 of at least 1 to stop the spread. Remember, spreading means that more people are getting it than the people that already have it. In this case, so more numbers in terms of, so more math. Think about it that way. So like our seasonal flu, what we had is that one person gave it to another person, and then the numbers were stable. But here in Ebola and measles case, 1 is giving it to 2, 2 giving it to 4, 4 giving it to 8, so it's starting to spread. In the case of measles, for example, that was 1 gave it to 15, and then after that, 15 will give it to 225. Think about it that way. Okay, so the numbers spread out significantly faster. So what do we want? We want to reduce that R0 down to 0. And one of the best ways to do that is reducing the effective contact, meaning less people coming into contact with each other. So social distancing, so isolation or quarantine, that's the idea of what's taking place right now. But if we really want to stop this, we would like to kind of bring this R0 down to about 0. In other words, we want to eradicate the disease. We really want it to go away. So let's see how we can actually kind of attempt to do this kind of control. Right, so I'm going to only look at the last 2 scenarios here. Okay, so we're going to look at small variations in there. I'm going to look at, for example, SARS, which I've changed up into something new, and that one has an R0 of 4. Okay, now here's where the kind of the math comes into play, and see if we can kind of play around with this. So again, these are just hypothetical, but this is the idea. In our first case, remember, we want to try and reduce the R0 to about 1. These cases have an R naught of 4 and an R naught of 18. So they're spreading, they're propagating, they're getting bigger, basically, and lots of people are going to get sick. And if they don't go under control, pandemic, basically. Now for SARS, so let's look at case 5 over here. If it has an R naught of 4, okay, the idea would be that for every one person, 4 other people get sick. So if there's 5 people here that we're looking at, 20 others will get sick in the next round. And then after that, 80 people, and so on and so forth. So it's going to spread out really, really fast, right? Now, our goal is to make this R naught a 1. Currently, it's at a 4, right? So how do we do this? So this is kind of part of the haunting of your math back in the good old days of taking trig and all that good stuff, right? Is that formula that I give you gives us an estimate of how many people get sick. Now, so our goal is that we want to reduce that R naught to 1. And so how do we do that? Let's use that formula I showed you a little bit earlier, is that we want to bring the people down to a number that is controllable, 1. So the people that get sick currently, okay, is basically 1 in 4. And the people that don't get sick, basically are 3/4 of that. So if that's our goal, what we're trying to aim is that less than 25% of people are getting sick, we turn that into a wonderful little formula. Basically, that's 1 minus 1 over R naught. Our R naught is 4, remember that. So the formula translates into 1 over 1 minus 4. That's the R naught value that we have over here. So how does this work? Well, let's see if we can kind of give you a breakdown of what we're trying to aim for and what that number really means. Okay, so the idea is what we want, or what is our hypothetical scenario. Okay, so again, we're using just SARS right now, and we'll continue with measles a little bit afterward. So again, if SARS has an R naught of 4, that generates 20 new cases for every 5 starting. So we start with the 5 little smiley faces or sad faces over there in the left-hand corner. And then we generated 20 new ones in the cyan blue color over there, right? Now to stop it from spreading, we would like an R naught of 1, okay? In other words, we would like to protect about 15 of those 20 and only 5 to get sick. Remember that an R naught of 1 means from 5 people, we give it to other 5 people, not 20. That gives us an R naught of 4. So the idea is if we want 5 to only give it to a possible other 5, that would mean that out of these 20, we want to protect 15 of them. We want only 5 of these guys to get sick. The other 15 we want to protect. In other words, our goal, like it's written up here, is that only 1/4 of those guys get sick, and then the rest do not. So we want 5 of them to get sick, not 20. So 5 get hit by the disease, the other 15 of them do not. And so that formula, as we're writing it, becomes 1 over minus 1/4, or gives us 3/4. That's what we're protecting over here. Okay, the people that don't get sick. That's our goal. That would technically then change our R naught down to 1. Okay? So what does that mean? Just by logic, tells us that if we want to keep it down to an R naught of 1, we want to protect 3/4 of these guys, or 75% of them. So what's the word protect here? What do we change that into our field? Well, the word protecting from disease is almost synonymous in this case by vaccination. In other words, if you want this disease to stop from spreading, in other words, to stabilize at an X equals 1, an R naught equals 1, I'm so sorry. In this case, meaning that only 5, give it to 5, no more, so it doesn't spread, we would have to protect the other 15. We would have to protect the other 3/4 of that population. In other words, we would have to vaccinate 3/4 of this population. In other words, to stop this disease from spreading, 75% of our population has to be vaccinated against this disease. Okay? Now we could apply the same disease concept to measles. Now remember, the measles is massive over here. So it has an R naught of 18, right? So a much bigger number. So what do we have here? Same idea, right? We want 5 to hit only 5, right? So ideally what we have here is there's 90 people that are being infected because it has an R naught of 18. So for every 5, 90 other people get hit over here. And we want to bring it down to an R naught of 1. So that means we want it to only hit 5 of these little sad faces over here in blue or cyan, and the other 85 of them would need to be protected. So in other words, we would need to literally vaccinate successfully, mind you, 85 out of those 90 so that this disease no longer spreads, right? So that's 1 over minus 1 over 18. So doing the math over there, right? And so that brings us roughly a percentage of 94.5%. In other words, in order to keep measles from spreading, we would want to vaccinate 94.5% of our population to keep it from spreading, right? So now, think about what we've done with measles, for example, in several other diseases. In order to keep them from spreading, we really have to vaccinate a lot of people, just so we can get it down to that R naught of equals 1, meaning it's not spreading. It's still continuing, it's still propagating overall, it's stable, but it's not taking over any country or any population. It's just kind of moving on steadily. So this is kind of where we kind of establish this feeling of somebody that is anti-vaccination, is that if we want to really protect the rest of the population, we want to stop this disease from spreading, we're going to have to vaccinate 95% of the population to prevent measles from spreading. Now, that's only if we just wanted to be stable, not eradicated, not go away. So how do we get it to go away? We would have to change that R naught to less than 1. And so if we require 95% of our population to be vaccinated to just keep it stable, then we're going to have to vaccinate more than 95% of our population so that that disease goes away. Okay? So this is why this concept of an anti-vaxxer becomes a very dangerous concept, because we can't really vaccinate everybody on the planet. We just can't. It's unfeasible. So we vaccinate most of the people that we can so that we can protect them and prevent the disease from spreading. Now let's go back to our practical application of this concept of COVID-19, right? So here, I want to kind of just give you this idea of what's going on. And so if you remember the original lecture, in several of the slides, we kind of just added a few more to cover this idea. But understand that SARS-CoV-2, which is the one that's causing COVID-19, currently has an R naught of about 2 to 3, right? And so as we're starting to define this disease, right, the disease is what we can measure, right, the fever, the lungs, and so on and so forth. The issue here is that as we start looking into controlling R naught and controlling the serial interval, now we're dealing with the sickness itself. Remember that the sickness is what impacts society. And that's what is happening to us right now, okay? The idea is what's happening is people are losing their jobs, people are not going to school, things are shutting down, and so on and so forth. That's where the sickness comes into play, right? That's that definition. That's the societal impact that we're seeing. And obviously, the experience that the host is having, you, the patient, if you will, is the one that gets the headaches, the malaise, they don't feel right, so on and so forth. And then the disease itself is the part we measure. Now, currently, the numbers that are being reported for the R naught of SARS-CoV-2 and COVID-19 is about 2 to 3. So let's just pretend it's 3. And so if we utilize this information, according to these formulas that we're showing you here, we want to have this 1 over 1 minus R naught. In other words, we want to keep it from spreading. So what is 1 over 1 over 3? So 1 minus 1/3. That means the answer is 2/3. So to keep this disease from spreading, to keep this from making it worse for us, we would have to vaccinate at least 2/3 of our population to prevent it from becoming stable or from continuing this epidemic. 2/3 of the population of the world would have to be protected, basically. That's what we're be aiming. Now, if we want to get rid of the disease, we would have to vaccinate more than that. So that's kind of where this math comes into play. That's where that R naught becomes a very useful number. And so anytime you want to kind of bring this idea of why vaccines are important, it's literally behind controlling the spread. It's not necessarily about you and whatever you believe. That's perfectly fine. You have those rights. But it's about everybody else. So that's where we start considering these things. So now let's take this information and apply it to our topic, to our lecture, right? So reminding you that, for example, when we defined pathogenesis, this means the progression of the disease, we talked about how, for example, this particular disease is going to spread. And so the pathogenesis and development of the disease is kind of always explained in 5 basic steps, right? Now, here what we're looking at is the 5 stages of disease progression or pathogenesis. The first step being here what we call an incubation period. And so this occurs as this kind of point of contact or entry state. And we'll go into this in a little bit more detail. We see something that we call kind of a latent state, in which basically there's no signs or symptoms. You're not experiencing anything. You're pretty much normal at that point in time, simply because the pathogen numbers, the agent numbers, are not high enough to have an effect upon you. Now, what determines how long this period is truly is a massive combination of information. Not only does it depend on which pathogen it is, obviously, it makes sense, but also the virulence of that pathogen. So how strong or how dangerous that is. Remember, there's various different strains of a pathogen, right? But it also depends on your immune status. So how strong your immune system is, whether you're a child, whether you're in an elderly stage, or somewhere in the middle of your life, also will change how long that incubation period takes place. And then it also depends where the site of infection was. You know, somebody sneezes on your hand versus somebody sneezing straight into your mouth, big difference in this case, right? So these actually kind of change the length of incubation. So more of a direct contact versus more of an indirect contact. So now the other issue behind here is that during incubation period, most patients are unaware they have been infected. You don't know that you have anything. So that's what makes that incubation period dangerous, and also very important to know what the length of time is. Now, outside of the incubation period enters the prodromal phase or prodromal period, in which this is when you start experiencing mild signs and symptoms. They're not very specific. You just start getting kind of those headaches, those backaches, those joints hurting, that kind of thing. So nothing that you can point at something. And so you start experiencing general signs and symptoms of an illness, okay? And that usually comes as a result of your immune system kind of starting to detect that something's a little off. And so you detect things like fevers and pains and soreness, that kind of thing. That's where this all starts. That's what the prodromal period happens. The problem is that anytime you get sick, these are very common symptoms, right? The same thing that happens to you for almost every infection gives you almost the same type of response from your immune system. A little bit of fever, a little bit of soreness, a little bit of being tired. So they're very difficult to explain what's causing that. And so this is one of those things that is popping up in a lot of discussions out there, is that whenever you get the flu, you still get those same types of symptoms. You get a little bit of fever, a little bit of soreness, a little bit of a backache, a little bit of a headache. So we've gone to this situation in which anytime we experience those things, we just call them flu-like symptoms. And it doesn't mean that it's the flu. It just means that those symptoms that we're experiencing, that's what we compare it to, right? So pretty much every metaphor on the planet, when you describe, oh, it's flying as high as a bird, or it's as tall as a mountain, or etc., we're just comparing it to something else. So this group of signs or symptoms, fever, pain, soreness, headaches, and so on and so forth, are now being alluded as a metaphor of saying they look like a flu. That doesn't mean you're getting it, but that's the metaphor we use for it. And so unfortunately, people are now mistaking it for a flu, and it really isn't the case. It provides you with the similar types of signs and symptoms. It doesn't make it a flu, right? So during this prodromal period, you experience these so-called flu-like symptoms. It's not the flu. It's just the fact that that's how we use to compare it, right? So these signs and symptoms are too general to point at any disease. So right now, some of you even undoubtedly may feel like that. Right now, you may feel like, oh, you know what? I'm not feeling too hot. My back hurts, headache a little bit, and I'm getting a little bit of a fever. That doesn't mean you have the disease. That just means you're experiencing the same group of signs and symptoms that your immune system always triggers. And that doesn't mean you're going to die. That doesn't mean you have COVID-19, for example. It just means you're experiencing that group of signs or symptoms. And so those are too general to really indicate to a particular disease. So this is at that point in time when you're not feeling too hot, then you start going, oh, I think I'm coming down with something. Something's happening to me. I think I might be getting sick. That's when most people start kind of making that claim. And then you enter the third stage, which is disease, right? This is also known as a clinical period, in case you're wondering, in which the disease pretty much reaches its full potential and all the signs and symptoms that are probable or impossible usually arise. And that means usually the pathogen, the agent, is at its highest. It's pretty much overwhelming your system. And at this point in time, it's a battle between you and the agent itself. Now, assuming a decent immune system and everything else, eventually during this clinical phase, you're going to win. Your immune system is going to kick in if it hasn't already, right? And then you enter what we call a period of decline or a decline phase. And the idea here is that the disease begins to relent, okay? The signs and symptoms start decreasing their intensity and frequency, and the number of the agent, the number of the pathogen starts to go down. And so as these start going away, that usually means you will eventually get the chance to win. That's the hypothesis. That's what's supposed to happen. Now, again, this is all based on you, your health, your immune system, the amount of nutrients that, for example, the pathogen has, the amount of access, and so on and so forth. So it's a large combination of things. Now, ideally, though, because your immune system kind of is being depleted here, and even though the organism may be declining, you're kind of open here. And so it's quite possible that something else may hit you here. So this is probably one of the more dangerous phases to be in. Because right now you fought the good fight, you won, but you've kind of depleted all your resources, which means that a second infection could easily overwhelm you and possibly even kill you. So this is kind of one of the issues behind the period of decline. Yes, the first pathogen that you encountered is going away, but you're also kind of tired of that battle against it. So secondary infections become a critical factor. So this is something that we take care of in most hospitals, right? When people are starting to see like they're recovering, every now and then you see them hit back. You'll see them get worse. And this is because, again, secondary infections can take place. Other organisms can take advantage of that period of weakness that you have and overwhelm you and possibly even kill you. So this is a very dangerous state to be in, if you will. Now, after assuming no secondary infections take place, you enter that final stage, stage 5, called the convalescence period or the period of convalescence, right? And in this case, this is your recovery, right? And this is a state in which the patient, the person that is sick or ill or has a disease, starts recovering after you got rid of the pathogen. At this point in time, there shouldn't be any more bug. There shouldn't be any more agent. The only thing that is happening here is that you're regaining your original health status. You're going back to homeostasis, right? So there's no more signs, there's no more symptoms of the disease. Okay, everything's gone away, the agent and the signs and symptoms. And here, it's your ability to recover. That really depends also on your health state to go back to where you were originally. So you are recovering all on your own, right? Now, there's a few more extra steps here and there that can be described, but these are your typical 5 that we talk about, these 5 steps of disease, for example. However, one of the biggest issues here is that since we call this the 5 steps of illness or 5 steps of disease, you may want to be careful. This is a little image that you see in the top right. These are something what we call the Kubler-Ross model, for those of you who've ever heard that before. And those are referred to also as the 5 stages of grief. And so be careful, because anytime you look for 5 stages, you may find the wrong thing. It has nothing to do with us, whole different model. So be aware of that, by the way. Now, what we want to do is kind of explain how does this incubation period take place. And the easiest way to kind of look at that is, again, through what we call this mechanism of pathogenesis, so the progression of the disease. And the most important piece here is how does it gain access to you? And so one of the key factors that we take a look at here is what we call is exposure. In other words, the host, the patient, if you will, something about them, their skin, their epithelial tissues, some sort of target tissues exposed to the causative agent, an environment brought them together. And so the first key step behind this, just like we described in Koch's postulates and etiology, is that they have to come into contact. The agent and the host have to have a common environment. Typically, what we call exposure is the agent coming into contact with the host through some sort of what we call portal of entry. It has to gain access to something of you. That's the environment that usually gives the agent access to you. Okay, so here what we're going to do is kind of trying to understand how does an agent cause the kind of structural and functional impairment upon entering the host. So we'll look at more or less each one of these steps kind of carefully and kind of emphasize what does each of them do. So first concept that we talk about here is this kind of portal of entry, right? In which we previously discussed what types of things could come into contact with you. And we talked about things like droplets and fomites or a vehicle and so on and so forth. But the way that they gain access to you is what we call the portal of entry. And they're the top 3 that we normally describe. The first one is all your mucosal membranes, right? So anything, any epithelial type tissue that is usually exposed towards the outside. So that means things that get access to you inside that have contact with the outside. Your eyes, for example, your nose, your mouth, your ears, the genitourinary tract. All of these things are things that have access to the inside of you that are exposed towards the outside. So one of the more common portals of entry are your mucosal membranes. The other one is what we refer to as the GI system or your parenteral route, right? The idea here is that your mouth more than anything else, can gain access to lots of things that can enter from your mouth to your esophagus, to your stomach, to your lower intestine, and so on and so forth. So anytime something enters or exits the alimentary canal, your GI route, that's another portal of entry, right? And then lastly, one of the key barriers that we have in terms of our immune system, one of the non-specifics, is your skin, the integumentary system, right? And then here, anytime something breaks that barrier, you can easily kind of colonize and take over and access the blood or something like that. Now, please note that all these categories can be subdivided or sometimes even combined, mind you. You can have combos of each of these exposures as well, right? But nonetheless, these are your classic 3, okay? Now, one of the key things that you should be aware, for example, is that there isn't just one portal of entry for something trying to get access to you. You can easily have something land on your skin, but also swallowed at the same time because you put your hands close to your lips or something like that. So there are multiple points of entry that can occur, but usually there is what we call a preferred portal of entry, in which an organism, even though it might access your eyes, your ears, your nose, your skin, or something like that, or you even eat it, but usually only one of them is the preferred method for it to gain access to you, and that's the one that will lead to ultimately to a disease. So, for example, certain types of salmonella, if you will, is typically only dangerous if you consume it, all right? But if it lands on your skin, you rub it all over your body, if you will, it might cause a little bit of a rash at best, but really won't harm you. But if you do eat it, you will be spending many, many days in the bathroom and with some pretty heavy fevers. Strep, for example, certain versions of strep, Streptococcus pneumoniae, is really only dangerous when it's inhaled. In other words, it'll trigger pneumonia in this case, or a version of pneumonia, I should say. when you inhale it, when you breathe it in. But if you eat it, it actually does absolutely nothing to you, right? Probably one of the more common ones, for those of you who are familiar with these and a little bit of history, things like anthrax and the Black Plague, right? So organisms like Yersinia pestis and Bacillus anthracis actually are organisms that are a little bit more versatile and really can cause disease regardless of which portal of entry they gain access to the host, right? So the idea here is that even if it hits you in the eyes or in the nose or in the skin, they'll still cause some damage. So some have preferred methods of entry, some of them don't really discriminate. Now, to understand the most key feature that is something we discuss in medicine a lot is the fact that just because you're exposed doesn't mean you're going to get the disease, right? Again, this idea of something being contagious doesn't imply that there's going to be an infection. Okay, so just because somebody sneezes you in the face doesn't mean you're going to start sneezing too. So what influences that chance? What makes it more likely that once it gains access to your portal of entry, that it's going to become dangerous? And so this is something that lots of biochemistry classes discuss, pharmacology classes discusses about a lot, and anybody in pathology discusses. This is called an infective dose. So this is commonly abbreviated as an ID, right? And the idea here is that this is the dose that is required to cause disease. And so we actually use kind of an average number called an ID 50, or infective dose required to cause at least 50% of the people to get sick. That's what that number kind of implies. And so different organisms have different ID 50s, meaning different quantities or concentrations required to cause you disease. And so let's go back to anthrax, for example. Believe it or not, anthrax in your skin, mind you, so this is the one we're going to be worried about, all it takes is about 10 particles. I'm not joking about this. I mean 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. That's what I mean. 10 of them are enough to take over and destroy your skin. 10 particles. However, for it to cause the same disease by breathing it in, it takes about 10,000 of them. And if you happen to swallow it, it usually takes about 1 million. So the infective dose, the ID that we're talking about over here, changes depending on the portal of entry. Now, anthrax will still harm you regardless of what portal of entry it is, but there's a different concentration for each. So it's most dangerous on the skin. An ID 50 of just 10, in this case, is incredibly dangerous. Now, cholera, for example, so this is the one that, still is kind of plaguing half of the American continent, for example, for bad drinking water, if you will, requires about 100 million particles if you actually consume it, right? But if for whatever reason you actually have a little bit of a pH change, you decide that for whatever reason you want to drink some alkaline water, okay? Meaning you're alkalinizing the fluid that you're drinking. So something that like sodium bicarbonate is present, or baking soda, if you will. It only requires now 1 million particles, meaning that you can make it 100 times more powerful just by making the water a little bit more alkaline. So think about that, right? So you're not feeling so well, your stomach is all messed up, your intestines are all feeling kind of weird, and you decide to take some Tums, something that alkalinizes the environment, you make cholera worse. So the infective dose, this ID that we're talking about, not only is dependent on the area of the portal of entry more than anything else, but also its environment. So we have to kind of be very concerned about what we expose to these particular agents. Now, in the case of, for example, SARS-CoV-2, the virus that we're interested in this case, currently, we know from all the current results that are out there, this is really an inhalational thing. So that means usually some sort of contact has to hit with your face most of the time, nose, eyes, mouth, that kind of thing, and that's usually how you go down. But believe it or not, Several other things have been proposed. It had been proposed that, for example, the fecal oral route was possible, in which that meant that if you went to the bathroom and somebody had used it before, coming into contact with the feces themselves, the toilet itself, or the water associated with it somehow might take you down. That is not true. There's no evidence for it whatsoever, and people have tested it. There's no such thing. So nobody's getting basically COVID-19 from toilets, if you will. It had been suggested that because people are sneezing it, that it's suddenly airborne. That's not the definition of airborne. Airborne in this case means that it's present in the air constantly and eventually will reach a host that eventually gets the disease. That's not somebody sneezing on you and suddenly you getting it. Although there have been studies that are testing the airborne capacity of COVID-19, of SARS-CoV-2, and according to the current evidence, by using these incredibly hard blowers, like turning rooms into little hurricanes, if you will, yes, you can technically aerosolize the virus, and technically it could be airborne. But seriously, nobody sneezes as hard as a hurricane, as far as we know. So there's no indication that technically it could be airborne. Now, the other place that it's definitely a possible contact is through fomites, coming into indirect contact with somebody that did sneeze, did touch something like a surface, handrails, kitchen counters, door handles, that kind of thing, and then you bringing it to your face, and then it gaining access to you. So this is going back to this concept that we talked about before, like respiratory droplets, depending on the size, whether they're nuclei or not, and those gaining access, those viruses lasting there. Now, the issue behind the research here is the fact that, yes, in the lab, a fomite containing, in this case, SARS-CoV-2, was still infectious up to about a couple of days, which, again, that's kind of dangerous, meaning you should be cleaning things. But that's a lab scenario. And as much as I appreciate my research and as much as I love research, that's not how we maintain our houses. So this ideal environment in which everything is squeaky clean and there's nothing else around that could harm a little droplet of the virus, or a droplet of the fomite containing the virus in this case, I should say that, is not how we run our houses. We're constantly moving things in our houses. We're constantly cleaning, wiping things down. There's other things growing on our kitchen counters and our toilets as well. So the likelihood of it lasting 1 to 2 days without cleaning is highly unlikely in a real case scenario. At best, what we've demonstrated in research is that those fomites, for a couple of hours, could remain infective in a real case scenario, right? So that means still, for a couple of hours, is still dangerous enough. So don't touch stuff, right? So wipe things down constantly as much as you can. Now, this is, again, assuming you're outside. If you're in your own house and you haven't come into contact with anybody, don't really need to worry about that much, right? So be aware of the data that is kind of out there. So now, overall, though, what we know is that the transmission behind this virus has to occur through direct contact with people, meaning somebody's touching you, shaking your hands, you're rubbing your face, that kind of thing, or through some sort of indirect contact with certain surfaces. So that means your immediate environment, like counters, rails, doors, that kind of thing. But again, for a very small, limited amount of time. So for us, really, the main case scenario is respiratory droplets. So somebody sneezing, somebody coughing, somebody breathing on you, somebody talking to you at a close enough distance that you can become infected. Now, fomites also can become a little bit of a dangerous scenario, because I want you to think what happens when you go to a hospital. And you, as a healthcare provider, technically are in contact with fomites all the friggin' time. Think about the use of a stethoscope, for example. That is a surface, and that is touching other people. And so for whatever reason, a droplet, something in the air, a sneeze, a hand, whatever it is, comes into contact, and those guys are not clean, you could feasibly transmit it to somebody else. So you kind of can't let your guard down behind this. I'm not trying to scare you. I'm just kind of trying to emphasize what is available and what are the possibilities. But as far as we know, the main way of contact is through respiratory droplets from people coming into direct contact with one another, so person to person, usually by access to your eyes, nose, and mouth. The other version of it is through indirect contact. usually through some sort of surface that has come into contact previously with somebody that was infected. So that's kind of that whole story kind of put together. Now, as we continue to expand it gaining access to you, there's various different forms. So we got this kind of transmission down, but that doesn't mean necessarily that it's going to infect you. That's how it could gain access to you. That doesn't mean you're going to get the disease. Remember, contagious does not imply infection. In order to actually you to be infected and get the disease, it has to stay inside of you and defeat your first levels of immunity, right? So the first level behind this is called adherence, meaning it has to stick to you. Not only it has to land on you, but it has to stick to you. So sure, you can rub your face with the virus or touch a kitchen counter, if you will, but it has to stay on you as well. Okay, so this is what we call adherence or adhesion, right? And it can be done through various different mechanisms, and most of them is usually by coming into contact with something on your cells. So usually that means some sort of contact with a cell wall, with a membrane, with some sort of proteins in there, and exchanging some sort of electrostatic interaction. So there's a little bit of an electricity contact that is occurring there. Now, for example, in bacteria, so bacterial adherence, most of it occurs through some sort of interaction with the overall surface area of a cell. And we usually kind of divide it into what we call specific and non-specific. Not that you really want to know too much behind that, but the contact that occurs between the bacterium and its host is usually referred to as docking. And so what will happen is we get either electrostatic or hydrophobic interactions, for those who want to remember your topic 2 chemistry that we had talked about. And there is a little bit of an ionic, so an electrolytic, if you want to think about it that way, interaction between the outside structures of a cell, so that peptidoglycan, that capsule that we had studied in the lab, and so on and so forth, that come into contact with the cell, they interact, and they hold on to each other, basically. One of the most common ways that this occurs is through something called a glycocalyx, and the irony behind this is that it's sweet and sugary. A glycocalyx is basically a very large coat of sugar that is nice and sticky, and it sticks to its particular host, or it's some sort of environment that keeps it there. Another common one is, again, that LPS, the lipopolysaccharide layer, that cell wall that we had talked about during bacterial morphology, that possesses these specific types of lipids called teichoic acids of gram-positive bacteria that allow them to kind of interact and attach themselves to certain surface areas, right? Now, there is kind of portions of them that involve something like molecular motion that allows them to kind of stay in certain areas, keep them from being moved along, but those are a little bit more difficult to usually explain. More common ones is some sort of interaction between the host and the agent by some sort of electrostatic interaction, some sort of electric attraction between them that causes them to stay there. Now, under the specific versions of these that we're kind of going to describe, probably the most common one alludes to that handshake that I talked about during viruses, for example, but this occurs in bacteria as well, in which there is a permanent interaction between substances that are kind of complementary. In other words, there's something on the agent and there's something on the host that can come together and pretty much interact in a very specific fashion. This is something often called anchoring, in which the molecules on a bacterium or something else, they're known as something we call adhesins. And so these are surface molecules that are present on the cells or on the outside of the bacterium itself that interact with the host itself. Some of the examples of adhesins are things called ligands, for example, in which they kind of interact specifically with receptors on the host. So the most common ones, for example, here are like the ones that work with gonorrhea. So Neisseria gonorrhoeae has proteins that interact with the surface of target host cells, and then they stay there physically attached. Another version of them is called a fimbria, in which these are kind of little hairs kind of sticking out of cells. That's the image that you're seeing there, right? And so, for example, lots of enteric bacteria, lots of the gut bacteria that we have, including E. coli and other Shigella species, kind of use these guys as little extensions as a way to kind of attach themselves specifically to a host. And then one of the ones we described when we talked about plasmids, especially the F plasmid we talked about, they gave it the ability for certain organisms to trade or swap DNA. They gave them this cool little structure called the pilus. And so the pilus, so the one that is involved in bacterial conjugation, it can be used to kind of attach itself to things and also colonize. So there's lots of different scenarios in which not only does the organism can land on you, but it can stay on you. Now, there's kind of interesting that there is a group of adhesins, a group of substances that like to stick to the host, and it's done through very, very specific sugar, a very specific carbohydrate called mannose. Okay, and so certain cells display this carbohydrate, this sugar, displayed on the outside of certain cells. And so on the plasma membrane, lots of these adhesins like to stick to that sugar. They have a very kind of specific interaction with mannose. And so if we display mannose, lots of these organisms love to go attach themselves to that too. Now, we can give you other examples associated with this, a little bit more specific or more easier examples to kind of explain. And one of the common ones that you might be familiar with is plaque. So the same plaque that forms on your teeth forms as a result of having excess sugars, again, this idea of a carbohydrate, that kind of interacts with the adhesins of things like Streptococcus mutans and certain Actinomyces species, and also Veillonellus. And so because we have lots of sugary stuff kind of sticking around our teeth, hence the whole idea of, brushing your teeth as well as not eating too much candy, right? There's plenty of organisms, plenty of pathogens, and plenty of agents that will love to stick to the sugars there. Now, a slightly different version, the one that you're seeing on the left, for example, here is syphilis, right? So here, a wonderful organism called Treponema pallidum, okay, uses part of its tail to kind of insert itself, to stab itself into tissue and literally remain attached. So that's a slightly different variation behind that. And then for us, the one we're going to discuss briefly here is another version in which viruses can do that. And so the proteins that are outside the virus, in this case, can also act as these adhesins, if you will, right? Now, outside of the virus, outside the casing of the virus, there's certain proteins, okay, that can interact in a very specific manner with their host. And this is, again, that idea I always spoke to, like a handshake. They have to kind of recognize each other, and then one will allow the other one to come in. In other words, the host will then recognize the agent and literally just kind of allow it into the body of the cell itself. Now, one of the examples that I can give you here, and it's similar to other ones that you'll hear later on, is in the virion that you're seeing here, for example, is in the influenza one. So the one that causes the flu, if you think about it that way. Now, what's unique about certain viruses, especially the ones that are enveloped, is that these viruses, when they exit the host, once they destroy it, they take a little chunk of their host. They take a little coat and then kind of wrap themselves around it, and they end up kind of looking like the original host in a smaller scale, right? So the envelope that these virion end up having ends up being stolen from the host and usually kind of gets filled up with certain glycoproteins, so certain proteins that are modified with carbs, in the shape of little spikes. And so this is kind of what you're seeing over here. They look like little things sticking out from the membrane that is encasing the particular virus. Now, for your classic influenza viruses, there's two main spike proteins. One of them is known as the hemagglutinin spike, and the other one is known as the neuraminidase spike. These are usually abbreviated as HA and NA in case you have ever seen them. But most of the time we get a little bit too lazy, and we don't even go as far as HA or NA. We just call them H and N. So these proteins, these spikes that are sticking out, get just the names, the acronyms associated with the first letters. And so various different strains of the virions behind influenza, type A, type B, and so on and so forth, are named after those two proteins. So H1N1, H2N2, H5N4, and so on and so forth come from those specific proteins that work as attachment points, right? Now, what's interesting about this is that our SARS-CoV-2 has a very similar fashion behind this guy. So we can show it to you here. And so these are models, mind you. These are not actual crystal structures, if you will. These are just people modeling them. And what you see is that the outside of the virus, in this case, has these spike proteins too. So one of the most infamous of them all is called the spike protein, as its name implies. And so it's known as the S protein. But there's a couple of other ones out there. There's an M protein. This stands for membrane protein. And then there's an E protein that stands for envelope protein, for example. And so all of these guys, these particular proteins that are kind of sticking out for them, serve as an interaction, like an adhesion, like a handshake, to recognize their host, stick to it, and then be allowed in. Okay. Now for us, more or less, the biggest interest that we have is in that S protein, the one that most people end up talking about. And it happens to be very loosely similar to the H and N proteins that are on influenza viruses. And so due to its spikes, that's where it gets that cool little spiky look, if you will, and hence that whole corona thing, right? The term corona meaning crown in both Latin and most Romance languages, right? And so because of these little spikes sticking over its body, that's where that kind of crown-like structure comes into play. Now, that S protein happens to be a ligand. It happens to recognize receptors on cells. That means that it can recognize something and stick to it, and therefore act as an adhesion, okay? So when we start understanding the pathophysiology of this wonderful little virus, right, the S protein is acting as this cool little ligand and interacts with a receptor, with the host protein called ACE2. So ACE2 or ACE in this case, which is how most of us refer to it. Now, for those of you who have taken AMP, you probably remember this term. So for those of you who studied a little bit of AMP and did hormone signaling, you probably heard of a pathway called the RAS pathway, or RAS. Now, RAS stands for renin-angiotensin system, RAS. And it's also kind of being referred to as renin-angiotensin-aldosterone system, depending on who mentions it, right? But in short, these are the hormones that connect the kidneys to the heart and a couple of other tissues. So renin being kidneys, angiotensin having to do with the heart and blood pressure, that kind of thing, right? And so usually this RAS pathway and these hormones involved in here are all controlling blood pressure and heart rate and so on and so forth, and how much liquid you're passing through your kidneys, hence they control blood pressure too, right? But in terms of impact, this RAS pathway that is influenced by this ACE2 receptor is the ligand binding portion for the S protein on this particular virus. In other words, the membrane protein that controls multiple organs involved in our life support functions, you know, and just at least one aspect behind it, the S protein of this virus acts as a competitive inhibitor. This S spike protein that you're seeing over here interacts with the ACE2 receptor. And when it binds with it, it competes with its binding site. It prevents the normal hormones that goes into this receptor and keeps it from happening. It blocks it. It inhibits it, just like we learned during our metabolic class. So the S protein is a competitive inhibitor against angiotensin 2, the hormone that interacts with the ACE2 enzyme, which means that if you block that enzyme from doing its jobs, if you block angiotensin 2 from doing its job, blood pressure is lowered. Basically, your blood pressure drops. And this is something that is very common, for example, in people that are trying to be treated with certain high blood pressure conditions, so hypertensives, if you will. We give them drugs that basically interact with that. We call them ACE inhibitors. You've probably heard that term before, right? Well, this virus happens to do the same thing. It interacts with that particular pathway, acts as an inhibitor, and causes a drop in blood pressure. Okay. Now, ACE2, this receptor, believe it or not, happens to be found in virtually almost all epithelial tissue and lots of organs, although it can be primarily found in your lungs, go figure, in your heart, kidney, and liver. And so, like most groups, mind you, again, I'm not doing this loosely, most classifications of coronaviruses are usually kind of upper respiratory type pathogens, meaning your nose, your mouth, your throat. SARS-CoV-2, on the other hand, for some reason has the ability to enter the lower respiratory tract and actually have some fun with the lungs. So its proteins are a little bit different enough that it can have lower respiratory effects. And this is where the whole coughing and having difficulty breathing comes into play. So to truly kind of explain how SARS-CoV-2 really works, I just have a few little images that I kind of want to show you on how this works in the lower tract, right? Now, here's the kind of the pathophysiology of the disease. Now, for those of you who remember your good old AMP, this might be a review, or this might be something a little extra. And so inside your lungs, okay, inside the cool little alveoli, those little air sacs that everybody learns about, okay, this is what you're seeing in the lower left-hand corner. Inside of it, I'm going to just show you one little alveolus, one little air pocket or little air sac that you're seeing up there, right? Now, in this little air sac, there are two main types of lung cells. These are called pneumocytes, and they're referred to as type 1 pneumocytes and type 2 pneumocytes. And those are the little kind of rods that I've kind of drawn inside this little structure, right? Type 1 pneumocytes are the ones that everybody gets to learn for gas exchange. So these are the ones that everybody gets to know that take in oxygen and kick out CO2 and so on and so forth. That's what those guys do. Everybody's kind of familiar with how those lungs usually work and help you breathe, right? But the type 2 ones, the other cells that are present inside the alveoli, function in, well, one of their main functions is to produce something called surfactant. Now, for those of you who remember bacterial control, we talked about these substances called surfactants. Surfactants decrease water tension. Basically, they make water more fluid. They make it more watery, if you will. It flows faster, okay? And so surfactants are these detergent-like substances that reduce surface tension. They make the water separate faster. Think about it that way. And so one of the main surfactants that humans produce is usually abbreviated as DPPC. Okay, we're not really going to get too far into that. It's not worth it. But I have a little doodle of it in the images, right? And so, and it basically looks like a regular phospholipid, right? So it kind of looks like this little spread out phospholipid like the ones we learned during the cell lecture. Now, when DPPC is combined with water and air, what it does, it reduces what we call the collapsing pressure of the alveolus, meaning it keeps that little pocket from collapsing on itself. In other words, us dying, right? So by reducing surface tension, it keeps the shape and the size of that cool little pocket, okay? Now, the type 2 pneumocytes, okay, in this case, happen to be very rich in ACE2 receptor, okay? So they have lots of the receptor on their surface. Reminding you again that what we saw in the previous slide is that the SARS-CoV-2 spike protein, in this case, happens to interact with that ACE2 receptor. So what happens when you come into contact with this virus, that ACE2 that you're seeing here in this purple little kind of Y-looking aspect, that's exactly where the virus goes. The virus loves to interact with that receptor, okay, and it becomes attached to it. This is the concept of adherence. Again, contagious being one part, infection being the other part. The infection here occurs because the virus comes into contact with this ACE2 protein and stays there. It manages to gain entry. So what we're going to cover here briefly is this concept of adherence. The virus literally has that S protein that we showed you earlier, and it interacts with that cool little ACE2 protein present in all our cells. So here we have a scaled up version of a type 2 pneumocyte. And now we have a little ACE2 protein in kind of this purple color that you're seeing up here. Now, once that S protein interacts with that ACE2 protein, so this is that handshake that we talked about during the virus lecture, for example, some interesting things happen. One of the things happen is now that adherence has occurred, remember it has to stick, now it has to get in. So sticking is one level, so sticking without being flushed away is part one, but now it has to gain entry into it. So that handshake that we were talking about, that recognition that occurs between the virus and the host is part one. Now, the spike protein that has the kind of little recognition point, you're seeing this kind of light bluish color over there in cyan kind of color, that's what kind of recognizes our ACE2 protein. Now, that's how it's going to get in. But interestingly enough, the other portion of the S protein that you're seeing there has a critical component to be allowed in. And so what will happen is that that little piece, that purple piece that you're seeing as part of the S protein, a little bit lighter violet, if you will, needs to be cut, needs to be kind of trimmed off so that it can gain entry into the cell. So there are other proteins called proteases, and there's a protein called TMPRSS2, there's two S's, I think I mentioned a third one, sorry, that cuts that little piece. And it actually cuts it twice, believe it or not. So it actually cuts a little piece of that kind of purple and blue area that you're seeing up here. And then once it does that, it kind of activates the ability of the S protein to trigger endocytosis. Now remember endocytosis from topic C, and so that means that the cell will literally internalize whatever it sees at its surface. So the interaction between the S protein and the ACE inhibitor and this cool little cutter that we have here kind of drawn out as a little scissors is what triggers endocytosis. So one of the things that happens over here is that then the virus gains entry. Now, for those of you who remember your 5 steps in the viral cycle from topic F2, remember the virus needs to attach, but then it needs to be able to gain entry. This is how this virus gains entry. It needs to be cut first through that cool little spike protein, that protein that gives it its name as a corona shape, right? It gets cut, and then the cell basically takes it all in. Now, the virus needs to make more of itself. And so for those of you who remember step 3 in the reproduction of viral cycles, so the synthesis stage, which may include assembly, right, is that this virus introduces a positive single-stranded RNA, okay? So that means it's one little strand of RNA basically ready to make proteins straight off the bat. You don't even need DNA for this guy, which makes it faster and a little bit more dangerous, right? And so pretty much SARS-CoV-2 and virtually all of its cousins, now we can call them coronaviruses, if you will, okay, are all single-stranded positive single-stranded RNA viruses. That means that they can make proteins immediately from ribosomes on the spot. And guess what? Your cell, your type 2 pneumocyte, has tons of ribosomes there ready. And so that means they can make proteins really, really fast. Now, what's interesting about this positive single-stranded RNA is that it has this weird modification that works like an operon in bacteria, meaning it can produce lots of proteins from one single strand at the same time. So just like an operon in bacteria, you had one controlling sequence and lots of proteins in the same strand. Well, SARS-CoV-2 and its cousins too, mind you, all do the same thing. These are called polyproteins. And so what happens is that all the pieces kind of are ready to assemble and all happen at the same time. One of the things that happens is, the easiest example I usually relate to people, if you've ever been bored, and if you ever played with the little cardboard boxes of cereal, and whenever they include like things like toys, you'll notice that you kind of have to cut all the pieces out and then assemble the toy. It's the same concept here, in which it comes with the large piece of a protein, and then all the little pieces are kind of cut off cut into the smaller proteins, and then they assemble the actual virus. So this is what we normally know as a polyprotein. So they do them all in one shot, really fast, really efficiently, and then this giant protein just gets cut up into tiny little pieces through proteases, and then those little pieces then assemble into our virus. Now, this guy becomes a lot more dangerous simply because it has another twist in which those positive sense single-stranded RNAs can be actually turned into negative sense single-stranded RNAs to make more positive strand ones. So it has this ability by something called an RNA-dependent RNA polymerase, or RDRP. Okay, this is what this guy stands for. And it allows it to make more copies of itself. So not only does it introduce its instructions to make polyproteins, to make lots of proteins, but its RDRP one makes more of its genome. And so this becomes a compounded effect that becomes very fast. Lots of instructions, lots of products, all kind of end up being produced in a very short period of time. And so what ends up happening is once all these proteins are made, the cell is virtually kind of blown up, and all the little virion particles now get released. Okay, so pretty much as we were covering with the topic of the class, we've kind of discussed the three main steps of pathogenesis. We showed you, for example, how both bacteria and other pathogens, including SARS-CoV-2, can gain entry into the host. But then once it gains entry, it has to stick to it. So this model of adherence, right? And once it kind of gets adhered or stuck, then it has to gain entry into the actual cell. So just like SARS-CoV-2, it does it through that ACE2 inhibitor, right? Now, how does it do damage? So how does it cause damage to the actual host? So here we're going to look at the cytopathic effects of viruses instead of bacteria, right? So reminding you how we're going to kind of deal with good old Immunology 101. We're going to kind of highlight the topics that you cover in AMP, and you'll eventually kind of cover in AMP, this idea of a functional system within your body, a part of your homeostatic mechanisms that are designed to protect you from pathogens and other diseases, right? So this is your immune system. So this is how we combine the aspect of immunology with pathology. They usually go kind of hand in hand and side by side by covering all three basic ways of non-specific and specific type of barriers of your basic immunity. So what we call innate versus acquired or adaptive immunity. So that's going to be our part 2 of this particular topic.